Ma'am, we are live now. We can start.
Thank you. Yes. So good evening, doctors. I'm Dr. Prachi from Michelle Healthcare, and I welcome you all. Good evening, Dr. Sucheta, ma'am. Thank you very much for accepting our invitation and being with us. So, ma'am is Director and Senior Consultant Gynecologist and Obstetrician from Harsha Hospital, Kompally, Telangana. Ma'am is trained in obstetric laparoscopy as well as obstetric sonography. Today, ma'am is going to speak on laparoscopy in female infertility. And may I request and invite ma'am for her talk with us. So thank you very much, ma'am, and over to you.
Shall I start now?
Yes, ma'am, please. Thank you.
Okay. Thank you for the introduction. Good evening, everyone. I welcome you all for today's CM webinar on laparoscopy in infertility, mainly female infertility. As we all know, laparoscopy slides, it's not next slide, it's not coming again.
Ma'am, can you please
Okay. So as we all know, laparoscopy is a minimally invasive surgical technique which is most widely used for evaluation and management of infertility. It is mainly used for both diagnostic and operative purposes. Diagnostic lab is done mainly to know the cause of infertility. So diagnostic lab is indicated in all cases of unexplained infertility where we could not get a conclusive diagnosis with the previous screening tests. And it's also indicated when in cases of doubtful tubal patency and in patients with resistant PCOS, mainly clomiphene resistance. So there is, so we can see that mainly diagnostic lab we are doing for tubal patency and unexplained infertility. So there is a considerable debate regarding the place of laparoscopy in cases of unexplained infertility, but it has been proven that it should be offered to all patients with unexplained infertility who are less than 37 years age, as a pathology is found in more than 2/3 of cases, and treatment with the laparoscopy can enhance the fertility in 20% of cases. So it's best to do diagnostic lab in all cases of unexplained infertility. According to the American Society of Reproductive Medicine, diagnostic laparoscopy is indicated when there is evidence or suspicion of pelvic endometriosis, pelvic adnexal adhesions, and in cases of significant tubal disease. Diagnostic laparoscopy is also indicated prior to applying aggressive empirical treatments like ART, so to prevent the potential risk to the unexplained infertile patients. And it should be strongly considered by clinicians with abnormal HSG result, a past history of pelvic infections or any surgeries, and or unexplained infertility during the management of an unexplained infertile couple. A laparoscopist should be ready to do the operative procedures like adhesiolisis and endometriosis surgery if the need arises. So diagnostic laparoscopy should be considered when there is abnormal HSG result, a past history of pelvic infections, pelvic surgeries, or unexplained secondary infertility during management of the unexplained infertile couple. So during laparoscopy, the surgeon can assess the pelvic anatomy, all pelvic organs, and detect any abnormalities in the pelvic organs like Mullerian abnormalities and fibroids in the uterus, detection of hydrosalpinx and peritubal adhesions in the tubes, and presence of PCOS and cysts in the ovaries. And we can also look for adhesions and endometriosis. In fact, diagnostic laparoscopy is the confirmatory for diagnosing adhesions and endometriosis. So now coming to diagnostic, but through diagnostic lab, we can also check the tubal patency. Tubal patency, we can check by doing a dye test through laparoscopy. Dye like methylene blue is passed transcervically, and we can check the spill through the femoral end. This is how we do a dye test. we can see the spill from the femoral end. So when we see dye test is negative on either side, we can go with the cannulation through hysteroscopy, cannulation of the tubes through hysteroscopy. So diagnostic lab should always be combined with hysteroscopy to diagnose any intracavitary lesions like intrauterine septum, submucosal fibroids, presence of any adhesions like as in Asherman syndrome, and we can take in a biopsy from the endometrium to diagnose endometrial TB, to check the hormonal status, and can do a histopathological examination of the endometrium. So diagnostic laparoscopy, surgeon should always be ready to proceed for operative laparoscopy if the need arises by passing small surgical instruments via the scope or through a separate incision. So now coming to operative laparoscopy, this is the overview of different procedures we do through operative laparoscopy. The procedures are broadly divided into 4 categories: tubal laparoscopic procedures, surgeries for endometriosis, procedures for PCOS, and leiomyoma procedures. So now coming to the tubal laparoscopic procedures, these are the different types of procedures which we do for tubal laparoscopy: adhesiolisis, procedures for distal tubal occlusion, proximal tubal occlusion, tubal reanastomosis, and prophylactic salpingectomy before proceeding for IVF. So adhesiolisis, all patients with pelvic adhesions and adnexal adhesions should be considered for adhesiolisis, because adhesiolisis improves the cumulative pregnancy rate over 24 months. So adhesions should be treated by doing adhesiolisis, and salpingo-ovariolisis should be done for adnexal adhesions. So distal tubal occlusion, the fimbrioplasty or salpingostomy should be considered for young women with mild tubal disease, because if successful, one surgical procedure can lead to several pregnancies, whereas IVF must be attempted each time pregnancy is desired. So IVF should be considered as the first line of treatment for moderate to severe distal tubal disease. So distal tubal disease, moderate or severe distal tubal disease, IVF should be considered. So proximal tubal occlusion or corneal occlusion is very rare, and the surgical treatment with resection and anastomosis is not highly successful. So we can try with catheterization of the tube through hysteroscope. So if it is mild obstruction is there, it can be relieved in few cases. Tubal reanastomosis should be considered in cases of mid-tubal blocks and for reversal of sterilization and in patients with previous ectopic. Still, in cases of sterilization reversal, the tubal reanastomosis gives good results only when the residual tube is more than 4 centimeters and when there is history of prior ring or clip applications. So in other women, IVF may be a better option. So the management of hydrosalpinx before going to IVF, it is a prophylactic procedure. So to increase the success rates in IVF, laparoscopic salpingectomy should be considered for all women with unilateral or bilateral hydrosalpinx prior to IVF treatment, because it improves the pregnancy rates. So hydrosalpinx is mainly diagnosed through ultrasound. On ultrasound, we can see hydrosalpinx as a thin or thick-walled, elongated, tubular, C-shaped or S-shaped fluid-filled structure that is seen distinct from the uterus and ovary. The folds inside the tube produce a characteristic cogwheel appearance. So we can see this. This is the ultrasound picture of the hydrosalpinx. Typical cogwheel appearance of the folds of the tube can be seen on either side. This is a bilateral hydrosalpinx on ultrasound. This is one more picture of hydrosalpinx on ultrasound, bilateral hydrosalpinx. Hydrosalpinx can also be diagnosed through CT, HSD, MRI, and through laparoscopy. This is a HSE picture of a bilateral hydrosalpinx. So why do we need to treat hydrosalpinx? So pregnancy rates were lower in visible hydrosalpinx compared to non-visible hydrosalpinx. So presence of bilateral hydrosalpinx has significantly lower pregnancy rates and lower implantation rates compared to unilateral hydrosalpinx. These findings suggest that the total amount of fluid in the hydrosalpinx is negatively correlated to the chance of achieving a pregnancy. So why do we need to treat hydrosalpinx? Because hydrosalpinx should be treated prior to going in for IVF, because the fluid acts directly on the transferred embryos, and it acts on the endometrium and decreases the receptivity for implantation. And the fluid also has embryotoxic properties. That is the reason we need to intervene the hydrosalpinx before proceeding for IVF. So the different types of interventions against hydrosalpinx, any surgical intervention should be able to interrupt the communication from the uterus and the tube to prevent the leakage of this fluid into the uterus. So there are a variety of procedures like salpingectomy, tubal ligation, and transvaginal aspiration, which are used against the hydrosalpinx. So salpingectomy is the most widely used intervention prior to going in for IVF. So there is significant improvement in the pregnancy rates and birth rates after doing IVF. And the clinical pregnancy rates are also more when the IVF is preceded by salpingectomy. So a systematic review in Cochrane library has shown that there is a significant improvement in ongoing pregnancy rate also if salpingectomy was performed prior to going in for IVF. So this is the hydrosalpinx which is seen on the laparoscopy without any additions. You can see that it's a tubular structure. So before proceeding to salpingectomy, the mucosal status of the hydrosalpinx has to be assessed before taking on the final decision for the salpingectomy or distal tuboplasty. So the cost effectiveness is also more when we do salpingectomy followed by IVF than going for salpingectomy after 2 or more failed IVF cycles. So hydrosalpinx should always be treated prior to going in for artificial reproductive techniques. It has been said that ovarian function is decreased in the ipsilateral ovary after doing salpingectomy. So to prevent that, it is important to be careful while doing the salpingectomy, and the vascular and nervous supply of the tube should be preserved. And it should be performed cautiously with electrocautery, with no unnecessary excision of the mesosalpinx. The resection of the tube should be very close to the actual tube to avoid damage to the medial tubal artery. And it is preferable to leave a portion of the adherent tube to the ovary rather than to perform an excessively radical salpingectomy. Tubal occlusion by laparoscopy is another method for tackling the hydrosalpinx, but it gives less results as compared to salpingectomy. It is only done when the salpingectomy is difficult to do in cases of pelvic adhesions, when there are extensive pelvic adhesions. So salpingectomy remains the first choice for dealing with hydrosalpinx. Tubal occlusion can also be done through hysteroscopy in cases of severe adhesions or in frozen pelvis. When laparoscopy is contraindicated, we can occlude the tubes through hysteroscopy. So it can be occluded by using Assure. It was the first use. It is a metal coil which is passed through the hysteroscope into the tubes and it induces a fibrosis and it blocks the tube. Salpingostomy is one more method for hydrosalpinx management. It is the method of choice if we are going for reconstructive surgery, but whether to go in for salpingostomy or not depends upon the evaluation of the tubal mucosa through the endoscope. And in tubes with more than half of the mucosa is in good condition, they have a fair chance of conception after doing salpingostomy. So drainage of hydrosalpinx at the time of oocyte collection is not as effective because the tubes will refill rapidly and the primary pathology is still there. Another method to deal with the hydrosalpinx is the transvaginal aspiration. So this, with whatever is the exact mechanism, the negative influence of hydrosalpinx fluids, the treatment options concern the disposal of the fluid. The simplest way vaginal aspiration of fluid has been evaluated in randomized controlled trials comparing transvaginal aspiration to no aspiration. It has been shown that transvaginal aspiration before ovarian stimulation was initiated. When transvaginal aspiration was done before ovarian stimulation was initiated, there was no improvement in pregnancy rates. So it can be concluded that transvaginal aspiration of hydrosalpingeal fluid at the time of oocyte collection is a treatment option, particularly if there is a contraindication of surgery or if the hydrosalpinx develops during the ovarian stimulation. So now coming to the endometriosis. Endometriosis, laparoscopy has a great role to play in diagnosis and management of endometriosis. There are two types of endometrial deposits, typical and atypical. The typical endometrial deposits, we can see they are bluish black with powder burn appearance. They are most easily diagnosed without need for biopsy. Whereas the atypical endometriotic lesions, they are non-pigmented. They may be white, yellow, red, or brown in color, and they lack the powder burn appearance. So these are the typical endometriotic lesions with powder burn appearance. And these are the atypical endometriotic lesions, which are white, red in appearance without the powder burn appearance. So endometriosis, this is another form of endometriosis in the ovary. It's a chocolate cyst. This is a laparoscopy. This is a picture of a chocolate cyst on laparoscopy, and this is ultrasound picture of the chocolate cyst. So endometriosis can be treated by doing ablation of the endometriotic spots through electrocautery, and the chocolate cyst can be excised and ablated. The complete cyst wall has to be removed, and care should be taken to prevent excessive removal of the normal ovarian tissue to prevent decrease in the ovarian reserve. So laparoscopy is also used for management of PCOS. In cases of resistant PCOS, laparoscopy is done by doing ovarian drilling prior, or it can be done prior to going for IVF and ICSI also. So it should be done with the diathermy, and the strategy of minimizing the number of diathermy points should be 4 per ovary, and it should be for a period of 4 seconds. Each diathermy should be for a period of 4 seconds, the power of 40 watts. So in order to prevent loss of the normal ovarian tissue and to decrease, to prevent decrease in the ovarian reserve. So this was all about female infertility. Now a word about male infertility. Laparoscopy also has a role to play in male infertility, mainly in varicocele. So varicocele can be done, repair can be done, varicocelectomy can be done either through open or laparoscopic method. To conclude, we can say that diagnostic laparoscopy is an effective method in evaluation of infertility, and judicious use of laparoscopy goes a long way in managing the infertile patients. Thank you.
Thank you, ma'am. Thank you for this excellent, concise presentation. Ma'am, couple of questions. Ma'am, if you allow me, I will raise a couple of questions. Ma'am, first question is there any role of laparoscopy as far as unexplained infertility is concerned?
Role of?
In case of unexplained infertility.
Okay. Unexplained infertility means we cannot come to a diagnosis what is the cause of infertility prior to doing. So in that cases, laparoscopy plays a major role. We can diagnose any presence of any adhesions, endometriosis, and so any other bicornuate uterus, presence of any Mullerian abnormalities can be diagnosed. So in a patient with unexplained infertility, laparoscopy plays a main role in coming to a diagnosis.
Right, ma'am. Right, ma'am. Ma'am, after the laparoscopy, would you wait for some time or immediately will you go for the ART option? So, like, how typically patients are treated?
It's after laparoscopy, it's better to wait for a period of 2 to 3 months before going in for ART.
Correct, ma'am. Will you wait for pregnancy? Then only you will decide as far as the treatment is ART treatment.
Question is not clear. It's echoing.
Now is it clear? Audible?
It's very loud and it's echoing. It's audible, but it's not very clear. Yeah, you can carry on now.
Getting some echo, ma'am. Prachi, ma'am.
Echo is there.
Now is it okay?
Okay.
Yes, ma'am. Now it's okay, ma'am.
Next question is how frequently the sterilization reversal is done and what is the success rate of this particular procedure?
Sterilization reversal, it depends upon the selection of the patient. Suppose if we select a young patient who is less than 37 years old, and if she underwent a laparoscopic clip or ring sterilization, then sterilization reversal gives good results. Otherwise, if the residual tube is less than 4 centimeters, and if the tubectomy was done through open mini lap, then the results will be less. So we should see to it that the residual tube should be less, at least 4 centimeters to get good results with sterilization reversal.
Okay. And ma'am, is there any age limit also associated with this? I mean, would you decide the age factor also considered whether to go ahead with this procedure or not?
Yes, it's better to do in women with less than 37 years of age, because if it is more than 37, they will have other problems like decreased ovarian reserve and male factor infertility may be also there. Such patients, they can better go to IVF instead of going for this tubal reversal, sterilization.
Right. Thank you very much. Ma'am, and the last question is the role of laparoscopy as far as the PCOS is concerned. I mean, is it only for the drilling purposes or the diagnostic purposes also this can be used?
In PCOS, we can diagnose and as well as treat. This we can do drilling and decrease the androgen excess in PCOS. So after doing ovarian drilling, they were more amenable to ovulation induction drugs, and the success of ovulation induction will be more after treating with this drilling, ovarian drilling.
And how patient selection? I mean, are there any criteria for who are these patients who should be going for this drilling?
Patients who are resistant to, like when we have tried with multiple cycles of ovulation induction with clomiphene, letrozole, and gonadotropins, and we fail to induce the patient, then we can plan for a laparoscopic ovarian drilling or in patients who are more than 37 years with PCOS, we can directly go in for this drilling and then go in for treatment. That would give good results.
Right, ma'am. Right, ma'am. Ma'am, thank you very much. I mean, these were the questions which were raised. So thank you very much. So with this, we can close this webinar. Ma'am, thank you for your excellent presentation and your support, and thank you very much. So, Yate, do you want to add anything?
Yeah, thank you very much. Thank you so much for a wonderful session, ma'am.
Thank you for the opportunity.
Close this.